Good morning. My name is Nils Mueller-Kronast. I'm the Regional Neuroscience Director for Tenet Florida North Group and the Director of Neurointerventional Service at Delray Medical Center. And I appreciate the opportunity to be able to present to you our discussions on pre-hospital stroke triage and the changes that should be made in the future all over the state. Here are my disclosures. I'm the National PI for the STRIDUS Registry, and I'll be presenting some of our data from that registry. It's important when we're talking about stroke to go back to the pathophysiology. Stroke is one of the most time-sensitive diseases with 2 million nerve cells being destroyed every minute. And by minute 0, every stroke is a TIA if you were to open the blood vessel immediately. And then at a variable speed in each patient, the core infarct increases to the size of the penumbral tissue, and then treatment is futile. So we have to obviously treat these patients as early as possible to effect change in their outcome. There are some patients that have excellent collaterals, and these patients can even be treated as a wake-up stroke up to 24 hours, which is why we're screening that long. And any patient in this situation can be treated at any system of care. That's not the challenging patient. The challenging patient is what we call the rapid progressor, patient with poor collaterals that will rapidly enlarge their core infarct until treatment is no longer helpful. And we need to build a system of care that can be optimized to treat these kinds of patients. Those are the patients that actually are the youngest with the most severe stroke. Those are the most vulnerable patients, and we should tailor our system of care to that. It all is contingent on the underlying plumbing. If you have good collaterals, you will have a better outcome than if you have poor collaterals, because then the stroke progresses more rapidly. And it's very important for us to understand which patients will need what kind of treatment. If you have a carotid T occlusion at the ICR terminus, your chance of being reperfused with IV thrombolysis alone is between 0 and 8%. So already we know that those patients with these severe stroke symptoms will need to be presented to a center that can treat patients with large vessel occlusions. We have a tool for that. It's called the RACE scale, and we've actually tweaked this RACE scale to focus on the signs and symptoms that predict the large vessel occlusion better. It's called the RACE plus score. The symptoms here are in green, with gaze deviation being the most powerful one, but unfortunately only receiving 1 point on the scale. The problem with the RACE scale is it's not perfect. It gives us some understanding, if you're under 5, they're usually milder strokes and they're usually more distal arteries, but you can have patients with very severe strokes with high RACE scales or low RACE scales. So they're not perfect, and that's why, if in doubt, you should go to the highest level of care, because these patients are unlikely to thrombolyze with IV TPA. And there is no time window for endovascular therapy, which makes it easier. It's important to look at the power of this intervention. When we look at the number of endovascular trials that have been completed to date, we can see that this is a very, very effective treatment. Actually, the number needed to treat to make one patient less disabled is 2.6, which is among the best in medicine. 1 in 5 number needed to treat to achieve functional independence. If you put that in context, the number needed to treat for other emergencies like STEMI, for instance, they're vastly higher than that. So this is the population that's most vulnerable and would be most benefiting from a system of care improvements. So what do we need to do? Why is it so difficult to triage acute stroke in the pre-hospital setting? The reason is that without special scans, these patients look very similar. They have a focal neurological deficit, but you do not know, do they have a bleed, a completed stroke, or penumbral tissue? And we've had all kinds of discussions about what technologies could be employed to do that, but in our scenario, mostly that's actually not going to be helpful. We looked at patients in the STRIDUS registry trying to understand what would happen if we simply optimized our triage protocol. And in this trial, or in this registry, we had about 1,000 patients, and we had patients that were transferred, and we took the timestamps and location data from where they went to the initial hospital and where they ended up being transferred, and just basically looked at if they had been transferred from the scene, instead of going to the initial hospital, if they had been transferred immediately to either the STRIDUS Center or another center called the Ideal Hospital that can do endovascular treatment. And we found a couple of very interesting things. First of all, we found that the time to take the patient in and out of the first emergency room is 103 minutes, door in, door out, which is obviously a lot of time if you're looking at these rapid progressing patients. And then what we did is we actually modeled and we subtracted the time by doing a Google map analysis, and basically looked at what would have happened if we had driven directly to a STRIDUS Center or the Ideal Hospital, and the number of excellent outcomes actually increased dramatically. For the excellent outcomes modified ranking 0 to 1, it would have been 16%. For 0 to 2, good outcomes, it is 13%. And if you take this information and just sort of casually overlay it over the outcomes of those patients, you can see that basically the outcome of the endovascular treatment is basically negated by where you make your triage decision to. So to basically say that a different way, it is as important if you do the treatment or not as where you take the patient. If you take the patient directly to the right hospital center, has the same impact as treating the patient. We here in Palm Beach have now 6 comprehensive stroke centers, 3 of which are externally certified. We, since 2016, have been bringing all of our strokes to comprehensive stroke centers up to 24 hours. And by June of 2021, this external certification actually will be required by law. And it's important to put that into context. You look at our system of care, you compare that with some of the locations that use CT-equipped ambulance, and you can quickly deduct that it's not going to be effective to have one CT-equipped ambulance if you have so many choices for thrombectomy-capable centers. That may be different for different geographies. But by making that choice and that change to bypass primary stroke centers and go directly to comprehensive stroke centers, and I have to give a lot of credit to Dr. Shepke for initiating this, and he got a lot of flack initially for it. We actually learned what these bypasses actually affect. And you can see here, this is data from the Tri-County area, Miami, Broward, and Palm Beach, and you can see that contrary to the expectation that treatment times to IV TPA would be longer, they actually became shorter because the comprehensive stroke centers, which we have a lot of, actually have better process times. The treatment within an hour from symptoms onset actually dramatically increased from 10% of the primary stroke center to 19% of the comprehensive stroke center. And the overall treatment rate also increased from around 11% in the primary stroke center to 18% in the comprehensive center, just because you have doctors that are more aggressive. The reason is very simple. We used to, for instance, have very low IV treatment rates because the physicians that were making the decision were not interested in IV treatment. They were office-based neurologists, and we basically changed this paradigm by bringing patients to the comprehensive stroke center where you have hospital-based vascular neurologists that are comfortable with TPA and give it all the time. And we're basically needing to do the same thing for interventional treatment because right now, non-interventional neurologists are making the treatment decision at non-endovascular centers, and they're counter-incentivized to do that. So the solution is obviously to bypass and not transfer. And we've seen the change. Here in South Florida, we have among the highest treatment rates with endovascular therapy. The problem that we have is that we still have a so-called zip code disparity. We have patients in comprehensive stroke centers receiving vastly different rates of treatment. Some comprehensive stroke centers delivering 3 to 5% of mechanical thrombectomy, and some others providing over 20%. So that's the challenge for us here in South Florida as the next step to improve quality, because CSC and CSC is not the same thing, and we need external certification. What we've been striving and we've been working towards is to improve the data that's available to the EMS medical directors. We now have a regional dashboard, county by county. The EMS medical director can now ask for this data with the guidelines, and you can see how each facility is performing. You see the rate of thrombectomy, and while this is anonymized, each medical director can ask to have disclosed which hospitals are behind which letter, and that allows you to actually make your treatment decisions, put people on notice if they're performing subpar therapy. We learned from this data, this is now published in Stroke in 2019, that there actually is a training effect. The more patients you treat per year, the more likely you are to treat patients. And that actually directly correlates with good outcomes. So for each additional cases, you get actually a 0.1 increase in the odds ratio, or 10% increase, because it's kind of like the trauma center. If you do something often, you will do it well. What we now need to focus on is process quality. We can see that the door-to-puncture time has dramatically decreased. You can see we started with 120 minutes as the Brain Attack Coalition recommendation in 2011, and in 2019, we have a 38-minute door-to-puncture median here in Palm Beach in some hospitals. So it's very, very possible to shrink those numbers, but it takes a lot of effort and a lot of discussion. you can see here the variability of the door to puncture time. And that's why having this data is very important, because it directly affects your treatment decision. Because if you see here 39 minutes or 109 minutes, you can drive a long distance in this time, in this 1 hour of time and process difference. The new metric actually should be not just the median time, meaning 50% or shorter, but actually the 90th percentile, meaning can you deliver this care in 9 out of 10 patients? And how do you get to these very aggressive treatment times? Well, you have to change your decision-making process. Should we be accurate or should we be fast? You have to limit the amount of imaging that you do before you make a decision to take the patient to the lab, and you have to get early notification. And we have some data on that. We actually looked at this and grouped our hospitals into 2 different groups, ones that have a conventional process and one that used a race pre-alert or even telehealth communication, and then have a streamlined imaging process and go directly to the lab. And we found, this was presented at the International Stroke Conference, that when you have pre-notification and do limited imaging, the door-to-groin time increases from 15 to 23.8% of the patients, and under 45-minute group increases from 30 to 55%. So 55% of those patients, when you have pre-notification, are treated under 45 minutes. And it's actually safer to do that because the rate of symptomatic hemorrhage actually goes down from 3.8 to 1%. In the non-transferred group of patients, the rate of treatment also increased. If you are faster, you treat more patients, and when you actually use video to triage, your rate of treatment can go up as much as 22% of all ischemic strokes. So there clearly is benefit in doing pre-notification and rapid triage. So in summary, transfers are bad. Bypass to comprehensive stroke centers improves all metrics: onset to treatment time, treatment in the golden hour, rate of IVTPA, onset to mechanical thrombectomy, and rate of mechanical thrombectomy. So in South Florida, where we have a lot of choices, the question is no longer, do I bypass, but who should I bypass to? And we should bypass based on external certification, overall stroke volume with at least 15 strokes per operator. That's now required as the thrombectomy capable certification requirement. We also know that low volume centers treat less and slower, and we need to look at the process quality. And just then you need to take that into account in your triage decision, because if the door to groin time is longer by 20 minutes, how far can you drive in that 20 minutes? What are your choices? The EMS dashboard, or the countywide dashboard, will provide EMS medical directors and fire chiefs with the data that they need to make their decisions. And these quality metrics should be as public as possible, for instance, at the emergency room wall. And we really need to take the next steps. We need to take triage from the hospital ER to the EMS scene and collaborate with EMS to really move that into the 45 minutes, which is otherwise our sonic wall. Thank you very much for this opportunity to present.